Well, thank you so much for such a kind introduction. Thank you so much for being here. And well, I should say thank you for this topic, but it's very challenging. It's a topic I've been working in for the last 10 years, and I have this feeling that the more I work on this, the less I know. So let's see how can I move on with this. And I will try to challenge the audience and to be open-minded. So, well, this is where I work, and all of you are invited to come to Madrid and to see our places. So see, this is the way I think we should think about this. I will start about the problem, and then we will move to the solution. And I think that here in the IPC, we are both clever and wise. We are going to solve the problem, but we also want to prevent, to avoid it. Why are we here? I don't have Mr. Bean here, but why are we here? So this is the issue. We know that our patients with psoriasis associate, I'm not talking about causality, associates an increased risk of cardiovascular mortality. We now know that it's an independent risk factor for cardiovascular disease. So here I start the challenge. I'm going to ask you, do you think that psoriasis is driving cardiovascular disease, or do you think that cardiovascular disease is causing psoriasis? Please, raise your arm, those thinking that psoriasis is causing cardiovascular disease. Does anybody here thinks that? Okay, around, let's say, 40%. Wow. Okay, now the opposite. Is cardiovascular disease could be causing psoriasis? Anybody here? Okay, nice. 30% of the room. Okay, then we have 20% absent. Okay, so logic versus reality. So I have always thought that psoriasis was driving cardiovascular disease, but then I read these two papers. So we have seen in epidemiological studies an association, but then causality is more difficult. And there are some robust methods for this to evaluate these Mendelian randomization studies. The first one I read was in 2022 from Good Johnson's group. And there they found that there was a signal that atherosclerosis could be in the directionality of causing psoriasis and not vice versa. This was first observation, but I remember my mentor, Dr. Gelfand, always telling me, Álvaro, one observation is just one observation. You need validation. So then in 2024, there was another study from Jonathan Barker and Catherine Smith, same Mendelian randomization studies showing the same, that cardiovascular disease was in the direction of psoriasis and not vice versa, and not in any other immune-mediated disease. So, well, at least this is interesting, and for me, this is hypothesis generating that maybe we could, for example, be using drugs for cardiovascular disease to treat psoriasis, like we are going to see here regarding obesity. But when I think about this, I say, okay, Álvaro, but this is impossible. I first see the skin lesions, and then they develop a myocardial infarction. But look at this. This is the things that we do in Madrid. We take image of the arteries of our patient with psoriasis in the coronaries, in the carotid, and in the femorals. And we see that early in the life of our patients, we scan them when they have 30 years old, and in an average age of 48, 77% of our patients has already established atherosclerosis. So, of course, atherosclerosis could come before psoriasis, right? And this can generate the hypothesis of using some treatments for cardiovascular disease to treat psoriasis that, like we have already proposed, and that can be used. And not only treating cardiovascular disease for improving psoriasis, but also there are some diets that have already demonstrated improvement in the general population in cardiovascular disease, like the Mediterranean diet, the best evidence-based diet for improving cardiovascular disease. We thought, okay, why don't we use this Mediterranean diet that has proven improving cardiovascular disease to improve psoriasis? And this is something that we have already done. We have done a small pilot study in Madrid. We give an intervention to psoriasis patient versus a control diet. This is our intervention. So we buy, with our research funding, olive oil, which is more expensive than the biosimilar of adalimumab in Spain. So now we are waiting for the biosimilar of the olive oil. This is the new results that we have. So these are patients that are already on a stable topical therapy. we put control group or intervention group, and they have an improvement in 3.4 PASI score, and we are now analyzing at the molecular level some cardiovascular proteins to see whether they can improve also, and also cytokines. So now I invite you to put the lenses of a cardiologist, and we are going to move from this dermatology meeting to a cardiology meeting to see what are they talking about regarding psoriasis. And we go there and we see their guidelines, and they already put the word psoriasis in their guidelines in both the United States and also in Europe. And more interesting, look at here. In their guidelines, they have a paragraph saying gaps in the evidence, and they want to know the role of our drugs in their patients. So we have the power here to evaluate this. And another concept that we should incorporate from cardiologists is this, residual vascular inflammation. So who in the room knows about residual inflammation? Anybody here? Okay, 3% of the room? Okay, residual inflammation is, in the cardiology field, those patients who had a first myocardial infarction, they are well treated based on the guidelines for cardiovascular risk factors, but they develop a second heart attack. That second heart attack is supposed to be by inflammation, and how they measure inflammation is by CRP levels. CRP, we don't use it in psoriasis. CRP levels above 2 is a residual inflammation risk of a second heart attack, okay? And as you can see here, it has more predictive value than cholesterol for a second heart attack. So I remember when I was speaking with Dr. Gelfand and asking him, why don't we use adalimumab in patients with myocardial infarction? And he told me, no, Álvaro, why don't you go to your cohort and you evaluate those patients who, after 1 year of biologic therapy, they are completely clear, they are good, they have a good skin response. How many of those has residual inflammation, CRP above 2? So we went to my cohort, then we go to Dr. Mehta's cohort and Karolinska cohort, 3 cohorts to validate the results. And we found that 30% of patients across internationally, in the different, 30% of patients with psoriasis successfully treated with biologics, 30% have residual inflammation. And the best marker was the body mass index. The body mass index, really suggesting that when you have a patient like this, and when you this, and you think that as a dermatologist you are done, you still have residual inflammation. So we still have something to do with these patients. And now we have done some analysis in our cohort to see coronary progressors in our patients, and CRP is a good predictor. So we still could include this marker in the future in the field of psoriasis. But I think this is the question we all want to answer, right? The million-dollar question. Does treatment of psoriasis modulate cardiovascular disease in clinical trials? And this question is important if you want to read the literature. And this is what we do in this, we did in this Journal of Investigative Dermatology paper that we published. It was during the pandemic. I couldn't access to the laboratory, so we did this systematic review and meta-analysis, which is a lot of work. With looking for those studies evaluating the impact of these treatments on cardiovascular disease in randomized placebo-controlled trials. And what we found is that there was, in the primary outcomes, no results, no positive results, except for ustekinumab, but then the result was lost after 52 weeks. So pure outcomes, neutral effect was the conclusion. Interesting results we found was that adalimumab improved some markers of cardiovascular disease and also phototherapy. And this IL-6 that has also been related with depression. So interesting results, hypothesis generating results. What about observational studies? Here we have more data. We have data from Dr. Mehta's cohort, and you can see how there is a positive response in the coronaries of patients in observational studies after 1 and 4 years of biologic therapy, but this has some bias that there is no control group, and you know that in observational studies, patients tend to behave better when they are on biologics, okay? But this was first observation, and then a second observation, I'd like to show you our results. So in Madrid, in Spain, in my center, we have another cohort of patients. We do imaging at baseline and after 1 year of biologics, and we scan those patients in the coronaries. We send the results, we send those scans to the NIH, and this is what we receive. And I like to show you this because it's so interesting when you discuss this with cardiologists and you see that after 1 year, what we think it could be so simple, you see that in part of the artery is worsening, the other part is improving, and it's so difficult to measure this. But this is what we receive. And here I will show you the first 58 patients. So what we see is that at least there is a favorable remodeling, so consistent with Dr. Mehta's results, with more stable plaques, with an improving non-calcified plaque, and a little bit of increase in calcification. This is what statins do. None of those patients are on statins. I have shown this to cardiologists, and they told me that there is a therapeutical effect there. That's not done by nature or by behavior. So this is only hypothesis generation, I insist, but it is interesting. But you may be wondering, what about any family of biologics? So these are our results, and this could be interesting because this is the first time that we show data on IL-23 on the coronaries of patients. And I know there has been lots of debate here, and you can see there that there is an decrease in non-calcified burden, which is good for your arteries, and an increase, a mild increase in calcification, not significant, but significant decrease in non-calcified burden. So positive results, good results. I'm not concluding, I'm concluding nothing here because this is just, I insist, hypothesis. I'm very cautious, right? Because my mentor should be, I know his mind. So, but this should generate new trials, and at least we can say to our patient, these drugs are safe for you. So I think this is good, and this is my summary. So if you ask me, I would say observational studies says yes, placebo-controlled trials we still don't know. But the most important thing or interesting thing for me is to think about the future. What do we need? So I've been thinking about this, and I have created this thing called NGPT, which could be a new working group for the IPC, the next generation of psoriasis trials. And I like that sentence. I was thinking, preparing this. Atherosclerosis is so difficult outcome because you can measure events, but you need to wait a lot, and our population is young. We got to go to the CT scan, which cardiologists use, but it's also difficult, as I have shown you before. We can measure so many things, and I will show now some innovative things which I think you will enjoy. Again, this is what I receive, and when they tell me after 1 year, the artery has changed, the anatomy is now more straight, so it's not comparable. So this is difficult, but what I like to share with you is this. This is what they call the natural history of a coronary plaque in the modern era. So we have been using for the last 20 years the calcium score, right? And the calcium score is just measuring calcium. And calcium sometimes is, well, calcium appears at the beginning of the natural history of the plaque, but then is healing. When you give an statin to a patient, it calcified. Our biologics has shown to calcified plaques. Cardiologists are not using calcium score in patients under statin, and maybe in the future we will not use calcium score in patients with biologics. So what they are showing here is that the first trigger of atherosclerosis is inflammation. You see there inflammation at the beginning, and then there is a non-calcified plaque, and slowly the part of the plaque is non-calcified and another part is calcified. Then some patients start statins, and statins decrease inflammation, decrease non-calcified, but you see that calcification goes just up, 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 up. So there is no way that you are going to measure or monitor the coronary plaque with a calcium score, okay? But then, as you can see, when you treat the patient, inflammation decreases. And then one day, there is another rebound of inflammation, and that's where, for example, they want to start colchicine now, or maybe in the future are biologics. They propose to use inflammatory markers in the coronary, like the pericoronary inflammation index that we are using now to monitor inflammation in the coronaries of our patients. We are now evaluating this in our cohort and even designing some small trials to evaluate this with our drugs. So for these NGPT trials, we should think different. We should look to other specialties. We should look for these HIV studies. Long follow-up of patients evaluating heart events, but this is tough and this takes lots of time. Also, we should think young people and young individuals. Here I am with my mentor, Dr. Valentin Fuster, and he was telling me, Álvaro, in the general population, I am putting patients from 20 to 40 in an LDL below 70. So if they are doing that in the general population, why we don't do that in psoriasis? And they follow them not for events, because that's so difficult. They follow them with imaging, with this cardiovascular imaging in the carotids, femorals, and coronaries. So my suggestion is this. So for this next generation of psoriasis trials, we should move away for this week 16, so maybe 5 years. We should include maybe mild patients with psoriasis. They are most of our patients, and they still have cardiovascular disease. Should be a pragmatic trial with not rigid inclusion criteria, maybe with thousands of patients, multiple comparators, hard outcomes, should have some sub-studies with now, for example, with TRMs, with CCTA. If possible, some patients free of drug. We should think also about lifestyle, this diet, obesity drugs, but who is going to pay for this? The finding is going to be difficult. Maybe should put them all together. Also, but this will give us definitive answers in many, many questions that other ways, like the one I have in this symposium, we are not going to be able to answer, and it will for sure improve the understanding on the natural history of the disease. Here is where I think I would like to finish with. So we are talking about curing psoriasis when I open the Journal of Investigative of Dermatology journal. No? And I think we should move towards this, because if we look at the last 20 years in psoriasis, if we were 20 years ago, we couldn't imagine what we do now in psoriasis. So I think now it's time to design how the next 20 years are going to be. And I like that sentence about ambition in psoriasis works, because we are talking about curing, about so many things. And of course, our patients deserve this. And I think that that's part of the IPC vision. A world free of psoriasis is possible. So that's why I wanted to give this final part. And I don't want to say goodbye without telling that Madrid is going to be a candidate city to the World Congress of Dermatology. So they told me that I should put this slide to all of you, and thank you so much for your attention.